Good afternoon. This is the Health Commission Community and Public Health Committee meeting for Monday, November 17th.
I will call the roll. Commissioner Gerardo
Here.
and Commissioner Salgado.
Present.
I will read the land acknowledgement. Thank you. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Approval of the Health Commission, the Community and Public Health Committee meeting minutes of October 20th, 2025.
I so move to approve.
A second.
Is there any public comment? I do not see any public comment in the room. All in favor?
Aye.
Great, thank you. Item 3 is an HIV STI update. Give me like 30 seconds to pull up. Maybe. Oh, actually, and before everyone begins, the HVAC system is very loud in here. And so it's difficult sometimes for us to hear beyond the wall and you to hear us. So please speak close to the microphone and enunciate and a little louder than you normally would, please. And then also, if anyone can't hear on either side, please just ask for clarification. Hold on. I'm sorry. Do that again.
Hello?
Yes.
Okay. Hi, good afternoon, commissioners. My name is Stephanie Cohen. I'm the director of the STI HIV branch, and I'll be presenting this update today along with my colleague, Naisha Underwood, who's the director of the Community Health Equity and Promotion branch. Next slide. Today, we'll be sharing with you how the San Francisco Department of Public Health addresses HIV and STIs through an integrated, patient-centered approach. This approach is informed by our local HIV and STI epidemiology, and we'll review trends in epi data at the start of the presentation today. Our approach relies on clinical and community-based programs that work to prevent infections and morbidity and to promote health equity. We will illustrate to you how rapidly implementing innovative strategies and partnering with health systems and with community is leading to progress in sexual health. Next slide. Both Naisha and I are from the Population Health Division, which sits in the Health Department under the leadership of our Division Director and Health Officer, Dr. Susan Phillip. We do this work in collaboration with the San Francisco Health Network, for example, with HIV Health Services, Ward 86, and the San Francisco Health Network primary care clinics. Next slide. Here you see the current structure of the Population Health Division. Today, I will present the epi data that's been prepared by our colleagues in the ARCHES branch, Applied Research, Community Epi, and Surveillance. ARCHES HIV is led by Dr. Arpi Terzian and ARCHES STI by Trang Nguyen. I will also provide updates on our clinical STI and HIV prevention programs that are led by the STI HIV branch, as well as the multi-sectoral work led by our SF Getting to Zero consortium. Getting to Zero was co-founded by Dr. Susan Buckbinder from Bridge HIV, one of our other PhD branches. And then Naisha will provide updates on our partnerships with community and our community-based HIV and STI programs led by CHEP branch. Next slide. We'll start with the EPI. Here you see the number of new HIV diagnoses each year from 2006 to 2024 in the red line, the number of deaths among people living with HIV in the green line, and in the purple bars, the number of living individuals who were diagnosed with HIV in San Francisco. New HIV infections have declined since 2019 by 23%, but this decline has now leveled off. And you can see that there was a slight uptick in infections from 140 in 2023 to 146 in 2024. There are now 15,400 individuals living with HIV who are San Francisco residents at the time of their diagnosis. Of these, 75% are over 50 years of age and 48% are over 60 years of age. Under 11% are under the age of 40. With this aging population, we can see that the number of deaths has been increasing. However, with improvements in treatment and care, HIV as a cause of those deaths has continued to decline, while deaths due to overdose, particularly opiate overdose, have risen. And overdose is now the second leading cause of death in people with HIV in San Francisco. Next slide. Transmission by male-to-male sexual contact accounts for the majority of the HIV epidemic in San Francisco. So most of our new cases are in cis men. Here you see the rate of HIV in cis men by race ethnicity. By looking at rate, which takes into account the size of a population, we can see disparities in burden of disease. Focusing first on numbers, the number of new diagnoses in cis men declined slightly from 113 in 2023 to 110 in 2024. 83% of new diagnoses in cis men are among men who have sex with men, and an additional 8% are men who have sex with men who also report injection drug use. When we focus on rates shown in the figure, we can see significant racial and ethnic disparities in HIV. The rate of new HIV diagnoses in Black African American men, shown in the green line on this figure, increased from 2023 to 2024. And in 2024, the rate in Black African American men was twice as high as the HIV rate in Latino men, shown in the blue line, and 7 times as high as the rate in white men, shown in the yellow line. The rate of annual diagnoses in Latino men was stable in 2024 compared with 2023, but is still almost 4 times higher than the rate in white men. Next slide. Now we turn to new HIV diagnoses in cis women. Overall, inclusive of all racial ethnic groups, the absolute number of new diagnoses in cis women increased from 14 in 2023 to 26 in 2024, so almost doubling. And the proportion of new diagnoses that were among cis women also rose, now to 18% of all new diagnoses in San Francisco. 15% of cis women newly diagnosed with HIV in 2024 reported injection drug use. So what that means is that most HIV infections in cis women are occurring through sexual exposure. Looking at the rates shown in the figure, we see a similar pattern to what we saw with men, which is that the rate of new HIV diagnoses in Black African American cis women, shown in the green line, jumped sharply from 2023 to 2024. The absolute number of cases in this group is small, but this striking increase in rate is still of concern and something we are responding to and monitoring closely. Rates of HIV diagnoses also rose for Latina women, shown in the blue line, who have the second highest rate, and for white women, shown in the yellow line. We think the increases in HIV diagnoses in Black African American men and women are related to multifactorial drivers of health disparities and inequality. We reviewed the 2024 cases in cis women, and we found high rates of psychiatric comorbidity, substance use, homelessness, and experiences of violence. We think that these drivers are playing a major role in limiting access and uptake of screening, prevention, and care, and we'll talk more about what we're doing to reach these populations later in the talk. Next slide. Here we see trends in new HIV diagnoses for several other select populations who are disproportionately impacted by HIV. Looking at the 5-year period from 2019 to 2024, you can see in the top row of this table that overall diagnoses declined by 23%. And they also declined in these other populations, 27% for people experiencing homelessness, 34% for people who inject drugs, and 36% for trans women. Cis women are the only group amongst these select populations who had an increase in new diagnoses over this 5-year period. Next slide. The HIV care continuum is a way of looking at how we're doing at getting people from knowing their diagnosis, into care, and getting on meds, and getting virally suppressed, which is needed to achieve health and prevent transmission. This figure, which shows San Francisco data in the blue bars, in orange data in the, national data in the orange bars, shows how we're doing with linkage to care and viral suppression. In 2024, 94% of people diagnosed with HIV in San Francisco were linked to care within 1 month, compared with 83% nationally. And 79% were virally suppressed within 6 months of diagnosis, compared with 71% nationally. So thus, San Francisco exceeds the US on these important care continuum indicators. Next slide. We'll now turn our focus to bacterial sexually transmitted infections. Chlamydia, shown in this figure in orange, gonorrhea in green, and early syphilis in blue. Early syphilis is syphilis that's diagnosed in the first year after someone is infected, and that's the most infectious stage of syphilis. All 3 of these STIs decreased in San Francisco between 2019 and 2024. Though, as you can see on the figure, the rate of decline was less for gonorrhea as compared with chlamydia or syphilis. Next slide. Much of the decline in STIs is attributable to doxycycline post-exposure prophylaxis, or DoxyPEP. DoxyPEP is a biomedical prevention approach to STIs in which an individual takes the antibiotic doxycycline after sex. It has been recommended in San Francisco for men who have sex with men and trans women since late 2022, when the San Francisco Department of Public Health became the first health department in the United States to release DoxyPEP guidelines. And we continue to work to support DoxyPEP uptake and implementation in clinical and community-based settings. You can see here in this figure that chlamydia, again shown in the orange line, and early syphilis in the blue line have sharply declined in MSM and trans women since we rolled out DoxyPEP. DoxyPEP is less effective against gonorrhea, which is shown in the green line, because most circulating strains of gonorrhea are resistant to doxycycline. So as a result, we haven't seen the same progress with gonorrhea that we've seen with chlamydia and early syphilis. Next slide. There are persistent and significant racial and ethnic disparities in STI rates, just as there are for HIV, which we're working to address through our programs. Here you see chlamydia rates by race ethnicity. Rates of chlamydia are highest among Black African Americans, shown in this figure in the purple line, and in Pacific Islanders, shown in the yellow line. Rates among Native Americans are not presented here due to low case counts. Next slide. Early syphilis rates are highest among Black African Americans in the purple line and Latine populations in the blue line. One encouraging finding is that the decline in chlamydia and early syphilis that we've seen from 2019 to 2024 has been seen in all racial and ethnic groups. Next slide. Lastly, here you see gonorrhea rates by race ethnicity. And again, you see highest rates among Black African Americans in the purple line, Native Americans in gray, Pacific Islanders in yellow, and Latine populations in blue. Next slide. Now we turn to adolescents and young adults. This is a very important population in the field of STIs because young people under the age of 25 have much higher rates of chlamydia and gonorrhea compared with those over the age of 25. And you can see that within this youngest age group, the racial and ethnic disparities are especially stark. Here you see that chlamydia rates are by far highest among Black African American youth, shown again here in the purple line, followed by Pacific Islander youth, shown in the yellow line. Next slide. Congenital syphilis is the transmission of syphilis from a pregnant person to a fetus. Congenital syphilis can lead to stillbirth or to severe illness in a newborn, including death. It is entirely preventable with timely diagnosis and adequate treatment of the pregnant person. And thus, every congenital syphilis case is considered a sentinel event, and preventing congenital syphilis is a top program priority. We therefore closely track syphilis cases in people who can become pregnant, as well as congenital syphilis. Next slide. And in San Francisco and across California and the nation, increases in syphilis in people who can become pregnant began in 2014 and have continued, with some leveling off in recent years. In 2024, there were 202 women diagnosed with syphilis in San Francisco. 15 were pregnant. There were 3 congenital syphilis cases in 2024, and so far, just 1 to date in 2025. Increasing cases of syphilis in women are associated with many of the same factors I mentioned when talking about increasing cases of HIV in Black African American populations. We see high rates of homelessness and substance use in this population. Next slide. We'll close our EPI update with an emerging sexually transmitted infection, Mpox. After the large Mpox outbreak in 2022, we have continued to see intermittent and sporadic cases of Mpox in San Francisco, but at much lower numbers. We tend to see increases in Mpox cases in the summer and fall after big events and gatherings. We are continuing to recommend and promote the Mpox vaccine and provide it to uninsured patients through our large sexual health clinics like San Francisco City Clinic and San Francisco AIDS Foundation's Magnet Clinic, as well as at our adult immunization and travel clinic. I'm now going to turn it over to Naisha Underwood, Director of CHEP, who will talk about our efforts to address these trends and disparities and advance HIV/STI prevention and sexual health. Thank you.
Good afternoon, Commissioners. Across our PhD branches, we are working collaboratively to implement integrated evidence-based strategies with a focus on reducing HIV and STI rates and eliminating disparities. Key strategies, which you'll hear more about, include ensuring low barrier access to STI, HIV, and Hep C screening through health access points, city clinic, and home testing. Supporting equitable access to biomedical prevention tools like DoxyPEP and PrEP. Supporting equitable access, ensuring linkage to care and partner services for those diagnosed with STIs and HIV. Collaborating with health systems, providers, and community partners. Outreaching and engaging with communities both in person and online. Building capacity through training, technical assistance, and development of guidelines, and wherever we can, we work to address social determinants of health that drive these epidemics. Next slide, please. One of DPH's strategies to ending the epidemics and decreasing disparities among populations disproportionately impacted by HIV, Hep C's, and STIs, and overdoses is the implementation of the health access points. The HAPs provide access to integrated low barrier whole person care. There are 7 HAPs, 1 for each priority population in blue. For each HAP is a coalition of CBOs that work together to provide a standard set of services to a specific priority population. And together the 7 HAPs form a CBO network, Each HAP is a coalition of CBOs that work together to provide a standard set of services to a specific priority population. And together the 7 HAPs form a CBO network of care. We have provided the CBOs that make up the specific HAPs along with a list of the standard of care services each of the HAPs provide in the supplemental materials. Next slide, please. In this figure, across all priority populations, the HAP served 9,355 clients in year 2, an increase from year 1. Here we see the annual numbers served by population in year 1, in blue, in year 2 in orange. As you can see, the numbers served increased for people experiencing homelessness, youth, trans, Black African American, and decreased in Latina population. Overall, the total number of clients increased by 11% in year 2. Next slide, please. In fiscal year 2, HAPS continued to offer STI, HCV, and HIV testing, both rapid point-of-care tests and tests conducted in the lab. Gonorrhea and chlamydia tests accounted for the highest test volumes. There were over 21,000 HIV tests, over 13,000 syphilis, and over 4,000 HCV tests. Next slide, please. Here you see the percent of HAP clients who are Black, African American, and Latinx shown in orange, compared with the proportion in the overall San Francisco population shown in green. As you saw from the EPI data, Black, African American, and Latinx persons are disproportionately impacted by high rates of STIs and HIV. Our HAPs are focused on reaching these populations, as you see here. They are overrepresented among HAP clients relative to their proportion of the San Francisco population. Next slide, please. In addition to looking at the quantitative data, we have also collected qualitative data to better understand program successes, challenges, program innovations, and factors driving client engagement at the HAPs. Several themes have emerged from this data. I'll discuss the first 4 that support the quotes on the right. One of those themes is equity and representation. Equity is foundational to all the HAPs. They have expressed having staff who reflect the communities they serve, help build trust and cultural relevance. Programs are intentionally designed with racial and gender equity at the core. One of those quotes I'd like to share: "It felt good to see Black people leading health events. It makes me want to come back and tell my friends." And this was from an Umoja HAP participant, which is the Black African American Health Access Point. Another theme that emerged was peer-led engagement. Peer navigators are a powerful tool for engagement for several of the HAPs. Their lived experience reduces stigma and makes services more approachable. This model fosters trust, especially among youth and marginalized groups. A quote: "The peer model transforms outreach. When youth see someone like them providing services, stigma drops and curiosity rises." This is from the San Francisco AIDS Foundation Peer Navigator. This is from the Lyric, which is the youth HAP. Another theme, which is client-centered care. The HAPs use a trauma-informed, non-judgmental, client-centered approach. This allows clients to be honest about their needs and behaviors without fear. A quote that I like to share here: "I like the people. The people are incredible. I like that there's really no judgment. And I like the fact that I've always been honest with my physicians in terms of my drug use. I know a lot of people that don't, and I feel like I really can say anything to any of them, anybody here, and not be judged." And this was a 50-year-old cis woman from the lobby, which is the health access point for people who use drugs and people who experience homelessness. And the last theme that I like to share was around cultural and language access. The HAPs expressed how language and cultural relevance are key to accessibility. Services offered in multiple languages, tailored to cultural context. This ensures clients understand their options and feel respected. A quote here: "When I visit the LHAP, which is the Latinx HAP, I feel respected and heard. They explain things in Spanish and help me understand my options for PrEP and testing." And this is from the Mission Neighborhood Health Center, a client. Next slide, please. Because youth, so people ages 15 to 25, have much higher rates of STIs, and disparities are higher for Black African American youth, it's important to highlight what we're doing for youth. So Lyric leads the health access point for the transitional age youth. Some of the partners here are Huckleberry, Homeless Youth Alliance, and the San Francisco AIDS Foundation. And a few of the highlights for the health access point are that they provide comprehensive youth-centered care, integrating sexual health and behavioral health services, including PrEP access, counseling, and support for youth experiencing homelessness, community engagement through outreach events, peer-led support groups, and equity-focused programming. And the peer model here is an integral part of this health access point. CHEP staff lead the Youth United Through Health Education program, in which they provide sexual health and other skill building workshops to CBOs, schools, and Job Corps. They provide peer education and other leadership development pathways. We continue to partner with Third Street Youth Center, and also on their Safe Sex Summer Youth events. This summer, they engaged about 50 youth, providing testing, resources, prizes, and food. Some of the strategic partnerships, we have quite a few, but I'll highlight the collaboration with the DPH-funded health educators, and then our active partnership in the Black African American Health Initiative STI work group that continues to expand STI screening and prevention for youth. Next slide, please. Oh, and just to back up, I wanted to address Commissioner Gerard's question around information, information around STIs and the, I think it was the, yeah.
Thank you. I'm always most concerned. I see teens and their regulars at the city clinic for chlamydia. It's like, oh, well. And so one of the things that I'm wondering is if we do outreach to the San Francisco Unified School District wellness clinics, particularly with what you were talking about, your posters or any information, because most of the high schools do have a wellness center and they're well used.
Mhm.
And I would just, if not, I'd highly recommend it.
Yeah. So over the last year, we've been rebuilding our youth program, and so we currently do have some meetings scheduled with SFUSD to rebuild our collaboration, and we're discussing our workshops again with them. So
That would be great. And
yes.
in just the actual materials that you have that could be put into all of the wellness centers, just like I said, poster, pamphlet, phone number of the city clinic, or how to, that would, at least for that population I see, it would be so helpful.
Yeah, and we certainly will do that. And we still also have our condom distribution programs in the middle schools and the high schools currently.
Okay, thank you.
Yeah.
I appreciate it.
I have a quick question regarding teenagers. Do you guys have the information on social media?
We do.
What's the
Commissioner, please speak at the microphone.
what's the name on the account or what platform?
So I have, so our youth page is coming up on a slide.
Okay.
Yeah,
I'll wait.
we do have that coming up. And we are still, we're currently like building out our pages too. So we're working with social media. Okay, so we're on this slide. Where am I? Okay, so one of our other key strategies with a focus on eliminating disparities is to train frontline staff to deliver community-based HIV, STI, Hep C, and overdose prevention services. CHEP trains about 200 community-based staff a year to become state-certified test counselors. This year, we also trained 400 people in overdose prevention and 150 people in stigma reduction and HCV linkage and navigation, and hosted 2 frontline worker summits, one entirely in Spanish. Next slide, please. And last, I'll highlight our strategy for outreaching and engaging with communities both in person and online. Our dedicated team coordinates community engagement across CHEP, City Clinic, PhD, and our community partners. The team plays a central role in organizing events, managing outreach, and aligning messaging across social media and public health campaigns. Our public health campaigns, PrEP Supports and Have Good Sex, have been especially effective in building trust with our communities. These campaigns have helped us expand our digital footprint and increase participation in the home-based testing program, which is a key public health initiative. In terms of reach, our campaigns have made a significant impact. We have reached over 3 million people across the Bay Area. We have generated 500,000 unique impressions showing strong engagement. Importantly, these campaigns are intentionally designed to reach Black, African American, and Latinx women and men, ensuring our messaging is culturally relevant and equity focused. On social media, we are seeing strong growth, and I have listed a couple of our social media pages here. On the ground, our outreach has been just as impactful. We have engaged over 5,000 people through 40 plus events. These range from large scale city events like Pride, Carnival, Sunday Streets, to more targeted outreach at schools and clinics. These in-person efforts are essential for building trust and delivering services directly to the community. And now I'm going to turn it back over to Stephanie, who will conclude by highlighting some of our clinical and public health programs and partnerships. Thank you.
Thank you, Naisha. So our LINKS team plays an essential role in our HIV and STI prevention efforts, including our congenital syphilis prevention work. LINKS is a team of disease intervention specialists. They ensure that patients with STIs are adequately treated and that people with HIV are started on medications within 5 days of diagnosis. We call that a rapid start. LINKS DIS also support patients with HIV, syphilis, or Mpox to identify and notify partners. This is called partner services. They link people newly diagnosed with HIV to care, and this year they've undergone additional trainings to be able to counsel and refer their clients to HIV PrEP and DoxyPEP. They also provide navigation support to people with HIV who are not in care. LINKS centers equity in this work. All of our DIS are Black, African American, Latinx, or other people of color, and almost 40% speak Spanish. They meet their clients where they are, including out in the community, in their homes, in the field. They work to understand the unique barriers that each of their clients face and address those barriers by doing things like providing transport to appointments, track phones, incentives, food support, and clothing. The LINKS team is one of the major reasons for our high rates of HIV linkage to care and viral suppression in San Francisco. Next slide. The LINKS team plays an important role in congenital syphilis prevention, as does our cross-department CS Prevention Task Force, which was formed in 2021 and brings together staff from the Population Health Division, including LINKS, with colleagues from Maternal Child Adolescent Health, Whole Person Integrated Care, and UCSF's Team Lilly to advance coordinated efforts to prevent congenital syphilis. In recent years, the group has focused on building capacity for low barrier point of care syphilis testing in key settings, as well as piloting distribution of home pregnancy tests to people experiencing homelessness. They support community education and engagement, strengthen partnerships to coordinate navigation for pregnant people experiencing homelessness, and they're working on health systems quality improvement initiatives. For example, electronic health record optimizations to make sure we're screening people for syphilis when we should be. These efforts have enabled us to avert the vast majority of potential congenital syphilis cases in San Francisco. Next slide. We showed you how biomedical prevention with Doxy-PEP is driving down STIs. And we've had a lot of success with PrEP in San Francisco as well. And we're optimistic that innovative biomedical HIV prevention strategies, in other words, new tools for PrEP, if rolled out equitably, will further advance our HIV Getting to Zero efforts. We have 2 new PrEP products on the market. Both are long-acting injectables, one that's given once every 2 months and one that a person just needs to receive once every 6 months and be highly protected from HIV infection. So through collaborative, multidisciplinary, cross-department working groups, we're trying to support the rollout of these long-acting injectable PrEP options by doing things like developing provider and patient-facing educational materials, working to engage the community and promote the new products so we ensure people are aware of them, including at the health access points. We're also building capacity to offer and administer long-acting injectables at City Clinic, at the SFHN clinics like MXM and Castro Mission, as well as at the lobby health access point, and really throughout our system of care. Next slide. So as we've highlighted throughout this presentation, multi-sectoral and cross-department collaboration and collaboration with community is essential to our work. Getting to Zero is a coalition that was founded back in 2014 to work towards our common goal of becoming the first US jurisdiction to get to 0 HIV infections, 0 preventable deaths, and 0 HIV stigma and discrimination. Bridge HIV, ARCHES, STI HIV branch, and CHEP staff are all members of Getting to Zero, along with over 300 members of the community, including folks from academia, CBOs, community members themselves, and industry. Getting to Zero helps to advance much of the clinically and community-based prevention work you heard about today. And Getting to Zero and SFDPH have together made significant progress over the last decade. And I've highlighted some of those accomplishments here. For example, seeing an overall 66% decline in new HIV diagnoses compared to a 17% decline in the entire US. Creating the first protocol in the nation for rapid ART starts, such that now in San Francisco, the median days from HIV diagnosis to starting medications to treat HIV is 0. Supporting increased PrEP use, which has increased from 10% of eligible men who have sex with men in 2014 to 56% in 2023. Getting to Zero helps to support collaborations to address disparities and emerging issues as they become apparent. For example, forming working groups to address an increase in HIV and Latin A that we saw a few years ago, or to address the rise in Black African American populations that we talked about today. Getting to Zero has also helped us to track these new products like Doxy-PEP and long-acting injectable PrEP to monitor for disparities and create responsive programming. And Getting to Zero supports an integrated approach. We call this a syndemic approach, so that we're bringing STI, Hep C, and overdose prevention into our HIV prevention efforts wherever we can. Next slide. So in summary, the recent increases in HIV in Black African American cis men and women and persistently high STI rates in Black, Indigenous, and people of color who are young reflect ongoing racial disparities. These disparities require intensified efforts to address social determinants and improve health through programming that is evidence-based, equity-focused, stigma-free, and low barrier, that's informed by and implemented in collaboration with community, that's inclusive of wraparound services to address social determinants. We're excited about the new tools we have in HIV and STI prevention, and we need intensive efforts to ensure equitable access to them. And as you've heard, our partnerships with health systems, with CBOs, and with community, and through our newly launched health access points are core elements of our response. Next slide. We want to again acknowledge the major role that our ARCHES branch plays in informing this work and thank Arpi Terzian, Sharon Pipkin, and Trang Nguyen, and the many epidemiologists in ARCHES who worked on the data slides for this presentation and who collaborate closely with our teams to share data in real time and evaluate our programs. We also want to thank all the staff throughout the Population Health Division and the network who work to support HIV and STI prevention.
Dr. Cohen, could you tell them what ARCHES stands for?
Sure. It is the one of the Population Health Division branches, and it stands for Applied Research Community Epidemiology and Surveillance. And so it's the branch that manages all of the reportable data that come in on these communicable diseases, as well as program data, so that we kind of really know what's going on with our trends and work. Thanks.
And that's not, we're done for now. Commissioners, let's see, is there any public comment in the room? All just staff here, so it's the floor is yours.
Do we need any public comments?
No, I just said there's no public
Oh,
comment.
there is none. Connected to the slides. So on slide 5, are there numbers for the age group 40 and under? I know the majority are older folks, but I didn't know if you had any 40 and under data.
Yeah, so I wasn't sure when you asked the question if you were referring to people living with HIV or people newly diagnosed, because
Newly diagnosed.
Yeah, we see pretty different trends there, right? So in the population that's living with HIV, only under 11% are under the age of 40. But when we look at new diagnoses, most are under 40. So about 65% are under the age of 40 of our new diagnoses. That's been pretty stable, but yeah, it does reflect who's more at risk for becoming newly infected.
Okay. The other on slides 6 and 7, one of my other questions, I believe, other than I was looking for any other hypotheses other than equity, but you had already answered that basically with other things. One of my concerns on slide 11, and as you were going through it, is with DoxyPEP and with PrEP. There's been just information in the media that the federal government is targeting both of those, which is of major concern. And have you received any information?
Yeah, so I think it's an extremely important issue how federal policies will impact our HIV STI prevention work overall and impact our communities on so many different levels. But specifically in regards to access to PrEP and DoxyPEP, one of the areas of concern is that the United States Preventative Services Task Force is, the body that makes recommendations around preventative services. And if the USPSTF gives a grade A recommendation to something, then an insurance company has to cover it. So because USPSTF has given PrEP a grade A recommendation, PrEP has always been covered by insurance. But just as we saw with ACIP, there may be some changes coming to USPSTF, and there's a lawsuit that basically questions that whole thing. But fortunately, California has put in place provisions to ensure insurance coverage for PrEP, even if that change unfolds at the federal level. So I think in California, we will be in a better position to continue to ensure access to these biomedical prevention tools.
Great.
Yeah, but we're following it
Okay.
and working to ensure the safety net is there.
Okay. On slide 17, which I need to refer to. I was wondering if there was any data for the multiple reasons for the increase in cases.
Was that this? Which
I don't know.
slide
I'm
was
going to
that?
look.
I think that might have been the syphilis
I was
slide that you were asking about.
14. 16. That was, yeah, that is the increase in the number of syphilis cases.
Yeah, so the initial uptick in cases really kicked in around 2016, 17. And this also has been occurring across California and across the nation. I think we see a lot of the same social determinants driving this epidemic. So things like housing instability, substance use, mental illness, and specifically in women who have a pregnancy that ends with a congenital syphilis case, we see some folks who have had prior experiences with child protective services and have fears about engaging with prenatal care. There's just a lot of intersecting vulnerability that this community faces. And I would say the other issue, especially earlier on, is that because most syphilis had been occurring in men, there was a lack of awareness of risk, both for women and their providers around the changing epidemiology. And so we've done a lot to address that as well and revise screening guidelines.
Right. In my other slide 25, I said, it's great work you're doing. But on slide 43 with the DPH citywide STI screening guidelines, my question there is, what clinics and programs other than DPH, receive this excellent information?
Yeah, thank you. That's a great question. Yeah, we included some of extra slides with supplemental information that we didn't have time to discuss today. But these are guidelines that we revise every couple of years and make available through the City Clinic provider web portal, which is a resource for providers around the city and around the nation. We also will sometimes push these guidelines out through health updates, as well as through continuing medical education talks that we give at clinics both within DPH and throughout the city through our training and technical assistance program.
The more they can get out to providers, the better, because a lot of times I know just in clinics, they don't always have time to go on
Thank you.
to kind of search for it, so to speak. And if it was, super readily available, it might even be easier.
Yes.
So,
Absolutely.
yeah, no. Okay, sorry to go ahead.
Thank you.
Thank you for the presentation and for all the hard work that you guys do. I have a very general question. The numbers for young people is really high and it looks like it's only going up. My question is, what outreach do you do that's different with the Black and Latino community that's cultural and religious based? Because there's a lot of taboos in our culture that I think are unique to our cultures.
Yeah, that's a really, really great question. Do you want to take that one? About outreach to youth of color, maybe like the 3rd Street.
Well, I mean, we're partnering with 3rd Street Youth Center. We've been also doing their summer youth series. We have our youth health access point. So that's also a collective of CBO partners who partner together to do work with youth. Let's see.
Is that outreach different than the general outreach for the youth? The reason I'm asking is because in the Black community, Latino community, there's a lot of cultural taboos that, we deal with within our own community when it comes to sex. So I was just wondering if the way we're approaching it, is it different from the general way of approaching other youths in the Asian community or the white community?
Well, I mean, I would say specifically the work that's being done with Third Street, also our Black African American Health Access Point. They're also doing some work specifically with Third Street, also for youth, and that's specifically for Black African American youth, and it's prioritizing, the community.
Okay. Thank you.
Thank you for the presentation and the excellent work that you continue to do and continue to step it up. Really impressive and appreciate it. Looking at, I suppose some of this might be centered on slide 25, but not necessarily sexual health education and services to youth through outreach. Can you give a sense of how present the department is in San Francisco Unified District generally? And I see these programs, school-based sexual health workshops, the health connected curriculum. I'm just not familiar with these things, and so I appreciate you taking some time to just level set for me how much presence and participation is there from about health concerns generally, and in the Unified School District. Is this is the department integrated from early ages through high school, or is it just some places where we are with programs like this?
Well, I can talk about, I'll talk about CHEP specifically, and then I don't know, Stephanie, if you want to.
I'm sorry, maybe this isn't the presentation for that. Perhaps it's a larger or different presentation focused on that, but I think the work that you're doing is critical, right?
Yeah.
And really important in reaching out to young people at all ages. And, I'm specifically also interested in discussions around sexual health and delaying sexual activity until a person is ready, and having that be a fundamental, basis for these discussions.
Yeah. So we have it's the Youth United through Health Education program. We have been rebuilding that over the last year. I think the last time I was here, we had gone through a lot of staff transitions. And so, now, we've been able to rehire. And so we are rebuilding those relationships again with SF USD. So starting those meetings again to repartner with the school district and, get back out there and do workshops again, in the schools. We also partner with the Chippy Clinics. We also are a part of BAHI, the Black African American Health Initiative. So there's a monthly STI work group that happens with a collective of partners. So that's the Department of Public Health, their CBO partners, and we're all getting together to discuss STI and how to tackle the increase of STIs among youth, and what we should be doing in different areas. And I don't know, Stephanie, if there's anything else you might want to add.
I'll just make, I'll add one comment on the Chippy clinics that Naisha mentioned. Those are the community health program for youth clinics that are run through the San Francisco Health Network side, so not the population health division side. But as you may know, the Chippy clinics have several that are based within SFUSD schools. So Balboa High, Willie Brown Middle School have Chippy embedded within those schools, but not every school has a Chippy clinic. But any high schooler in San Francisco can, public or private or parochial, can seek services at the Chippy clinic at Balboa High or any of the Chippy clinics throughout the city. So I think Chippy has is really the main liaison to working with SFUSD, and we're working on reestablishing, as Naisha said, some of those meetings and collaborating with Chippy to provide the population health perspective and information and services.
Thank you. That's really helpful for me. And I suppose that resources are one of the reasons why there are only several sites for this interaction.
I don't know the full history of how the Chippy clinics, ended up where they are, but yes, certainly I think that's one of the limiting factors. There's probably also, like, I'm just thinking of knowing some of the school's space and other pieces too, but yeah.
And generally speaking, is in an appropriate and useful way, is the message that it's okay to delay sexual activity and it's important to delay sexual activity until you are ready? Is that woven through and also part of all the information that young people are given? Because obviously so much pressure on them, generally speaking and culturally, in the youth culture and the adult culture that impacts the youth culture.
Right. Yes. And their access through social media. I have two tween teenagers myself. So Naisha already has a older, younger adult. Anyway, so yes, SFUSD, they have a robust sexual education curriculum that they really oversee and administer. And having kids who've gone through that in SFUSD, I've seen what they're learning, but we don't, create that curriculum for the school. So that was what I would say. That's not the health department's responsibility, but we support them with other types of resources and materials to supplement the curriculum that they deliver in SFUSD. So I can't really say like exactly how they work in that message, but we could certainly look at some of their materials.
And I would just hope that reminding, again, in useful ways, reminding the youth that are engaged with through these programs that, you are the mistress and master of your own body, and it's under your control, and do not let anybody blah, 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 blah.
Yes, I do feel that I've seen that message very strongly come through with what I've seen with the curriculum. Yes.
Thank you.
Thanks.
I'm just going to piggyback on your comments. I'd really push the wellness clinics.
Yeah.
Because they're in almost every single high school, and kids really flock to them for everything, and it would be an extremely simple task. And also Commissioner Salgado's communication about social media and websites. I mean, what these websites are, but I'd look at partnering if SFUSD has information, et cetera, on health, wellness, on TikTok. Or any of the others. I don't think you're going to see youth going on any of these others, because I think going to those that are used by them would be super, super helpful.
Yeah. And just to, again, continue to kind of beat the drum, these statistics that you've given us are horrific. And everything and anything that obviously we can do at the earliest stages and never stop letting up in getting the message to, kids who are under a lot of pressure and who are making decisions, adult decisions, way before they're ready to layer and layer and layer and layer that message, so that this is hopefully another avenue for those statistics to come down.
I just have a quick question on the Chippy clinics. Do the students need consent from their parents to?
No,
No.
they do
Okay.
not. There's California law that allows youth 12 and over to consent for services, sexual health services like vaccines and screening, so they can receive confidential services without parental involvement.
Okay. Thank you.
Thank you for this work.
Thank you,
Never.
everyone. And we can move on to item 4, which is emerging issues. Anything from you all, commissioners? Candace?
I would just like there to be, again, Mark, with your consideration and input and everyone else's, as much information as possible about what we are doing to reach and support the kids from preschool through, high school, and how, and the city Department of Public Health, I'd like to really understand what we are doing, how we have approached it, and given the new approaches that the department has been looking at over the last year, what we might be doing differently.
And Commissioner, is this a general public health when you're
Yes.
talking about that, or not
Yes.
not specific to this? Okay, great.
Yes. Thank you.
All right. And then
Wouldn't that be through like maternal child health, or
uh,
could they
it would,
coordinate?
but I believe the department has many avenues, so I'll have to talk to folks and see what this might look at like, and also then talk to President Green too, and then you, and and try to come figure it
Right.
out.
And the health network, and
Sure.
Yeah,
Yes, thank you.
because it's a group that's kind of an afterthought sometimes.
Yes, no, I know. Since you arrived, Commissioner Gerardo, it's been clear because you're the one who brings it up, and sometimes folks don't have that data. All right, item 5 is public comment. Is there any public comment in the room? All right, no public comment. And so before we leave, just again, a thank you to the presenters and the amazing work that y'all are doing. This topic is kind of a legacy of San Francisco. We're known as being on the forefront back in the day, and we still are. And it's wonderful to see the data, and we appreciate all that you do, and everybody down to the worker on the street. So commissioners, please consider a motion to adjourn.
So moved.
Second,
All those in favor?
Aye.
All right, thank you so much. Give me 30 seconds to close out.